patient, Mr. Chandra Prakash Singh. He's a 50-year-old male contractor by profession, resident of Lucknow, known diabetic, type 2 diabetes since last 3 years, hypertensive since last 3 years. He presented with complaints of generalized swelling since last 3 weeks and decreased urine output since last 3 weeks. So I'd like to start my history 4 weeks prior to the development of these symptoms, that is in the last week of November 2020, when he developed fever. So it was a high-grade intermittent fever, which occurred 3 to 4 times per day and was relieved with paracetamol. So this was associated with cough, which was dry and without any association with any expectoration. There was no chills on rigor associated with the fever, no loose motion or burning micturition. He had body ache when fever occurred. So he went to the local physician with fever and was told that he was having some viral illness, and he was prescribed with antibiotics, and he was also given painkillers for his body ache. So 4 to 5 days post this fever and taking antibiotics and some painkillers, his fever and his symptoms subsided. He did not give any history of any sore throat or skin infection during this episode. During this time, he remembers that to have a normal renal function, and his creatinine he remembers to be 1 during this febrile illness. 4 weeks post this episode, that is in the 3rd week of December, he developed generalized swelling of the body. So it was insidious on onset and gradually progressed. First, he developed swelling on both feet, which gradually increased up to the shins, and subsequently involved the face over the next 5 to 6 days. During this time, he noticed that he had a drop in his urine output, which was approximately 600 to 700 ml per day. There was no history of any red-colored urine or any froth in his urine. No history of fever or joint pain or rash during this episode. He did not take any painkillers or any medication or any alternative medication during this period. He also complains of a rise in his blood pressures. Previously, he used to take one drug to control his blood pressure, which now increased to 3 drugs which he required to control his blood pressure. He also developed exertional breathlessness during this time, and he had breathlessness while doing his daily activities, which he could do previously. This breathlessness increased by lying down. He, however, doesn't complain of any chest pain, palpitation, or syncopal attack during this development of breathlessness. He also did not have any jaundice, blood vomiting, or black tarry stool during this episode. He did his routine investigation at this time, and he was found to have a renal serum creatinine of around 5 this time. And he was also told that he had some evidence of blood in his urine, and there was also some leakage of protein through his urine. So he went to the local nephrologist in his hometown, and he was initiated hemodialysis. He was inserted a right internal jugular vein non-tunneled HG catheter, and since then he was on hemodialysis twice per week. He tolerated hemodialysis well. There was no fall on blood pressure, any fever or chill during his hemodialysis. 2 weeks post initiation of hemodialysis, his symptoms improved, swelling of the body decreased, and also his urine output also improved. Initially, the urine output, which was 600 to 700 ml per day, now improved, and he was passing urine of almost 1.5 liter per day. He also had a left brachiocephalic AV fistula made on December 21st December 2020. From there, he hospital for optimization of his treatment on the 3rd week of January. So he was asymptomatic on presentation to Medanta, and he was passing good amount of urine. He was told that at this time during admission, his serum creatinine was 4.2 milligram per dl. Patient was also told that patient also underwent an ultrasound, and he was told that his kidney size was normal, and he was planned for a kidney biopsy. His serum creatinine on subsequent days showed a spontaneous decreasing pattern without any hemodialysis. From 4.2 it decreased to 3 and then to 2.5 over the next 2 to 3 days. Hemodialysis was kept hold and he underwent kidney biopsy on the 22nd of Jan 2021. So this is the history of present illness. So in past history, there is no history of similar illness in the past, no surgical or any significant medical history, no history of jaundice, blood transfusion in the past. Family history, there is no history of renal dysfunction in the family. He has 2 children, 1 boy, 1 girl. No one has a significant history of any renal dysfunction. Personal history, no addiction. Bowel is normal. Sleep appetite is now normal. Bladder, there was decreased urine output during his presentation in December, and now he is passing normal amount of urine. Allergy history, there is none. Drug history, he is diabetic since 3 years on oral anti-diabetics, and he is taking now 3 drugs to control his blood pressure.
So, what is the urine color now?
Now urine color is clear, sir.
At any time, did he have gross hematuria?
No, sir, he didn't have any gross hematuria, but when he was evaluated in December last week, he was told by the physician that he was having some blood in his urine in the urine examination, but not frank blood in urine.
Okay, so what is your provisional diagnosis depending upon history?
So my for provisional diagnosis is acute nephritic. The syndromic diagnosis will be acute nephritic syndrome, and probable etiological diagnosis will be a post-infectious glomerulonephritis.
So, give me total diagnosis. You give me total diagnosis of the patient.
My provisional diagnosis is he's a case of he's a case of acute nephritic syndrome. This is a case of acute nephritic syndrome, probably due to post-infectious glomerulonephritis in a diabetic, hypertensive 50-year-old male, and he is currently in a state of recovery.
भाई ऐसे थोड़े बोलते हैं जी डायबिटीज हाइपरटेंसिव मेल, उसका बताओ क्या डायबिटीज है, कौन सा डायबिटीज है, व्हाट इज द टाइप ऑफ डायबिटीज, उसका डायग्नोसिस बताओ ना. टोटल पहले डायग्नोसिस, तो डायबिटीज है उसको या नहीं है? 3 ईयर से डायबिटीज है, सो ही इज हैविंग डायबिटीज. व्हाट टाइप ऑफ डायबिटीज? Which type of diabetes?
Type 2 diabetes mellitus.
Okay, so plus what about hypertension?
He's hypertensive since last 3 years now.
नहीं तो वो डायग्नोसिस नहीं है भाई. डायबिटीज हाइपरटेंशन ये पार्ट ऑफ डायग्नोसिस नहीं है.
ये सर बताएं.
वो बताओ ना. नाउ गिव मी द टोटल डायग्नोसिस ऑफ द पेशेंट.
Yes, my diagnosis is acute nephritic syndrome due to infection-related glomerulonephritis in a 50-year-old known type 2 diabetes, known hypertensive patient.
नहीं ऐसे नहीं बोलते यार. अगेन डायग्नोसिस में ये नहीं बोलना आपने नॉन हाइपरटेंसिव पेशेंट. नॉन एंड पेशेंट ये 2 वर्ड. अब तो मुझे डायग्नोसिस देना है आपने बस. You have to give me diagnosis. Number 1 diabetes,
hypertensive type 2 diabetes.
हाँ. उसके बाद
with acute nephritis.
नहीं, पहले डायबिटीज के बाद हाइपरटेंशन आया ना.
Yes sir.
तो फिर हाइपरटेंशन है. So that is part of, is it essential hypertension or is it secondary to diabetes? Is there any diabetic nephropathy in this patient?
No sir, in examination I didn't find any evidence.
अभी एग्जामिनेशन पे तो हम गए नहीं, अभी तो हम हिस्ट्री पे है ना. So history wise, is there any evidence, is there any point in the history to suggest that patient is having underlying diabetic kidney disease?
I think there's a hello.
Is there any underlying point in favor of diabetic kidney disease? Or do you think it is purely acute nephritic syndrome and kidneys were perfectly normal in this patient?
Like likely he was there was no evidence from the history. I couldn't get any evidence for to say that the patient was having any diabetic nephropathy underlying.
Well, now you have to justify whatever you say. So you mean to say that it is only acute nephritic syndrome,
Yes,
and
sir.
there is nothing to suggest underlying diabetic nephropathy, huh?
Yes, sir. Yes, yes. Sir.
Okay, and infection related
So
glomerulonephritis, what is the cause of IRGN? Why do you say post-infectious glomerulonephritis? But you said post-streptococcus glomerulonephritis?
No, sir. Streptococcus evidence from the history, I couldn't find a definite streptococcal evidence of streptococcal
So what is
infection.
your
But he
impression?
had some infection in the last week of November.
So what is your possibility?
Uh,
What infection?
so, sir, maybe streptococcal infection is most common, but he might be also be having any of this.
You have to give me answer, na? You have to give me the diagnosis clinically. What infection you are thinking? You are saying it is not post-streptococcal. Then if it is a non-streptococcal, then what infection?
Of any viral infection.
Okay, so you have given your diagnosis. Dr. Ritesh has joined. Dr. Ritesh, you will like to ask some questions here, please.
Yes, sir. Devan, you have just kept one diagnosis as your possibility. You should always explore and keep another option as well. Dr. Bhala was suggesting.
Yes, I have
just purely keep
I have
one
second,
option.
Second diagnosis also.
Yeah, so you should offer that. That's what Dr. Bhala has been probing you.
Yes.
You necessarily cannot rule out diabetic nephropathy on history, but there is a possibility that he might be having underlying diabetic nephropathy.
I mean, why you are so dogmatic? Yes, no, there is no diabetic nephropathy. How can you be so dogmatic without just on the basis of provisional diagnosis? That's what I was saying. Yes, Dr. Ritesh.
That's exactly what sir is saying, that keep your diagnosis broad, possibilities broad at the time of discussion on the history right now. Don't just narrow down. You might be knowing the diagnosis now because he's your patient. In the exam, you will not know the diagnosis, and neither of us know what this patient has. Whatever you have presented on the history, there are other possibilities as well. So you
yes.
As an answer.
Yes.
That is important.
Yes. Yes.
What else could have happened here?
What, sir, I would like to also keep.
What else could have happened?
Yes. Apart from the acute nephrotic syndrome, I'll also like to keep the possibility of rapidly progressive renal failure, probably due to acute interstitial nephritis, because he had some history of intake of antibiotics and NSAIDs previously prior to the development of these symptoms. Acute on chronic CKD, although his baseline creatinine was 1 at the time of his viral illness, he tells us so, but we do not have a baseline. He might be having some baseline proteinuria. We are not sure of that. However, it is lower down the list, but the possibility could not be ruled out. So these are my 1, 2, and probably third differential diagnosis.
So do you think that this is a normal, natural history of interstitial nephritis, that patient goes to the stage of dialysis and he gets dialysis, he is having hematuria, and he has accelerated hypertension, and now after dialysis without any treatment, he has responded? Do you think this is a natural history of interstitial nephritis?
No, sir. It more fits into a IRGN pattern, but still, because he had some amount of some drugs before he developed these symptoms, and there is a recovery. He might be having some during this course of his dialysis, and when he visited the nephrologist outside, he might be given some medication which he doesn't remember, after which there was a recovery. So although the more likely that the patient is having a IRGN, but I will still like to have an AIN as a second possibility.
Was he given any steroids during his treatment?
No, sir. He didn't say that he was given any steroids. He denied that. He didn't know. Actually, he was given some medication by nephrologist, but he doesn't particularly remember of any steroids that was given.
Okay. Now come to examination.
So examination, general examination is vitals. Blood pressure was 140 by 80, pulse 90, palpable in all four limbs, no radial or radiofemoral delay. Arterial thickness was normal. Temperature was 98.7 degree Fahrenheit. No cyanosis, clubbing, edema, jaundice, no anemia. Respiratory rate was 20 per minute. Higher functions was normal. He was alert, conscious, cooperative. And the systemic examination. First, the respiratory system, the cardiovascular system, he was having S1, S2 was normal. There was no murmur or any added sound. Apex bit was in a normal position. Respiratory system, he was having bilateral symmetrical movement of the chest. There was bilateral vesicular breath sound, no added sounds was seen. Abdominal examination, abdomen was soft. There was no tenderness, no scars, no organomegaly, and no tender points noted in the abdominal examination. In the eye examination, the fundoscopy showed there was no evidence of any diabetic retinopathy, and the CNS examination was also within normal limits. So examination, I did a routine urine examination also. That urine dipstick showed a protein of 4 plus, and there was presence of RBCs on the urine. There was no cast or crystals.
Protein is 4 plus. Eh?
Yes, sir.
And
yes, sir. 4 plus proteins.
No, it was a bland sediment or active sediment?
There were RBCs, sir. RBCs were 20 to 30 RBCs per hyperplate.
And RBC cast?
There was no cast, no crystals.
First of all, in the examination of abdomen, did you mention about genitalia? You didn't mention about his genitalia, hernia sites. No, you didn't mention about PR.
PR examination I didn't do.
No, but did you ask for a tray? Suppose patient is having some perianal abscess, and that perianal abscess could be the cause of this IRGN. Is there any diabetic foot?
No, sir. No, sir. No diabetic foot.
You mentioned about all peripheral pulsations.
Yes, sir. All peripheral pulses were palpable, equal on all 4 limbs. There was no delay in any. The arterial thickness was also
sometimes the patient can having infected diabetes foot. That could be the cause of IRGN. Patient may be having some deep-seated abscess, and the common sites of deep-seated abscesses are perianal abscess, any intra-abdominal abscess, liver abscess, lung abscess. How do you know? Diabetic patients are prone to get these kind of deep-seated infections. Okay. So now what is your final diagnosis after history as well as the examination?
So after history and examination, my final diagnosis means I will stick to the same diagnosis. Due to infection, glomerulonephritis, and my second diagnosis, rapid progressive renal failure, with the cause being acute interstitial nephritis. These two, I will stick to the same diagnosis.
And
after the examination
what
also.
about 4+ proteinuria?
Uh, in patients of acute nephritic syndrome, post-infectious glomerulonephritis, patients can have 4+ protein, nephrotic protein. They can have the
How many percentage of how many percentage of acute nephritic syndrome can have nephrotic syndrome? They can go into nephrotic syndrome.
20 to 30%
No.
in adults.
No, that is wrong. Dr. Ritesh, can you please continue with the discussion?
I just would like him to summarize the entire case. It will be good if you can summarize, because that will clarify a lot of things. So if you can summarize your history and then give a diagnosis, there will be more clarity.
Yes, so to summarize, my patient is a 50-year-old diabetic, hypertensive male who had an infection, probably a viral infection in the last week of November, for which he took antibiotics and painkillers, and the fever subsided. And then 4 weeks post this febrile illness, he developed generalized swelling with decreased urine output, for which he required hemodialysis. He tolerated the hemodialysis well. 2 weeks post initiation of hemodialysis, his symptoms improved, and his urine output also improved. And and then he recently he has a history of a spontaneous decrease in his serum creatinine, and then he underwent a kidney biopsy on the 22nd of Jan 2021.
So your symptoms are more of a subacute onset rather than acute. The patient presentation from onset of the febrile illness or the history of drug intake are about 4 weeks, isn't it?
Yes, sir, 4 weeks. Yes, sir, 4 weeks.
When you're talking about the course of even post-infectious glomerulonephritis, if presentation at 4 weeks is a bit unusual. You still want to keep that as your first diagnosis. When you look at the time course of the illness, it is more of a subacute onset, a rapidly progressive course one would see. But this has happened over a matter of few weeks, right? You might be knowing it's there on the biopsy, but when you look at the presentation, you have a 50-year-old gentleman who has diabetes and hypertension, has a febrile illness, don't say whichever it is, a febrile illness associated with some drug intake, following which about 4 weeks later, he gets all these kind of symptoms and is dialysis dependent. And a few weeks later, there is spontaneous remission, or probably because of some drugs he might have been given.
Yes.
So when you look at the time course, it favors a rapidly progressive course rather than an acute nephritic illness. See, you have to justify whatever is there on the history.
Yes.
So that's the problem. You should not know what is there on the biopsy first. You get biased.
Yes.
So how do you justify an acute nephritic illness when 4 weeks history, 4 weeks post illness, a person is developing symptoms and is found to have renal failure?
Yes, sir.
So it is a gradual symptoms. And it could favor more of a, if you say it's a rapidly progressive course, You can have rapidly progressive renal failure due to AN, well accepted. Because unless until he had shown spontaneous recovery, you would have thought about a lot of other illnesses. It's because of the recovery you're getting biased towards acute nephrotic syndrome, right?
Yes.
So you have to favor,
Yes, sir.
you have to point out what are the points in favor of this diagnosis and which are against it. You might not be perfect all the time. There are certain things which point in spontaneous remission. Yes, you can have acute nephrotic syndrome due to post-infectious. There are other causes of acute nephrotic syndrome, but in this case, it's probably some infection which induced it. And because of the spontaneous recovery, I am favoring the diagnosis of acute nephrotic syndrome. However, the time course is a bit protracted, as usually would happen in acute nephrotic illness. And that's where the second diagnosis comes in, where you're talking about acute interstitial nephritis. Acute interstitial nephritis is a rapidly progressive course. Yes, they could have microscopic hematuria. You were saying, Dr. Bhala is asking you, why is there 4+ proteinuria? What is the justification?
So,
He could have underlying diabetic nephropathy.
yes, sir. He might be having a diabetic nephropathy. We don't have a baseline protein.
So you really
before
don't
this.
know. That can be one possibility as well. So in the exam, whatever is the case, you have to justify based on your history. Basically, it's on the history. Very little is being added by your clinical examination. Just the urine routine is giving you something. And you examine the fundus. You would say, yes, there is absence of retinopathy.
Fundus did not show retinopathy. Yes.
Yeah. So you can justify a lot of things based on what you're finding. Don't be dogmatic about one thing only.
Yes.
You can say these are the points in favor and these are the points which are not in favor of this. Nobody's going to fire you for that. ठीक है ना sir?
Yes. So, 4+ proteinuria, easily you can explain that there could be patient could be having underlying diabetic nephropathy. And other thing is, of course, as you said, that not 30%, but about 5% of patients can have nephrotic range proteinuria. Okay, then how will you investigate this patient?
I'll do the routine examination, which includes a complete blood count and a renal function test, which includes urea, creatinine, and electrolytes. I will also do among the blood investigation. I will do the complement levels. And in urine routine, we already have a urine routine, so I would like to quantify the urine also, urine protein creatinine ratio, and like to do a ultrasound KUB to see the kidneys, and then I like to go for a after doing a coagulation profile, I will like to go for a kidney biopsy.
What about some serological tests you will do before doing kidney biopsy?
So in this case, I'll do the complement levels and as there is a spontaneous recovery in this patient, so I will not like to do the ANCA and the ANA. Otherwise, if the recovery would not have been there, then I would like to go for the ANA profile and the ANCA and anti-GBM also in this patient.
What is the commonest prototype of acute nephritic syndrome or acute glomerulonephritis? What is the commonest prototype?
Post-streptococcal glomerulonephritis is the prototype.
Yes.
Patient
So
presenting with
what is the serological test you do for PSGN?
ASO titers, and I will also do if the patients come. So I'll also can do anti-DNase levels. ASO titer we can do post-streptococcal.
चाहे आज की डेट में ना, if you are not practicing this investigation, but at least you should know that ASLO, CRP, complement levels, these are important. Okay, then what are the other possible causes of IRGN in a diabetic patient? One is, you said, some infection, bacterial infection, viral infection,
Yes.
or
Other than infection?
yes, no, infection, very important cause which you will do on investigation, right? Hmm? Infective endocarditis.
Staphylococcus aureus can also
Infective endocarditis. Have you mentioned about echocardiography? Did you mention about echocardiography in your investigations?
No, sir.
Why? If you don't do echo, you will miss the patient maybe having vegetations. Then any other infections? Which hepatitis virus can cause this kind of picture?
Hepatitis B. Yes, hepatitis.
Which
hepatitis
is more
A,
common?
B. Hepatitis A infection.
It is hepatitis C actually, which causes diffuse proliferative glomerulonephritis. Hepatitis A is not the cause.
Yes.
Okay. So this patient has diabetic kidney disease or non-diabetic kidney disease. Now we say that it could be 4+ proteinuria, it could be diabetic kidney disease. But could it be non-diabetic kidney disease like RPGN or like IRGN? Otherwise, what percentage of diabetic patients have non-diabetic kidney disease?
So I'm not sure of the percentage.
About 1/3 of patients can have non-diabetic kidney disease. Even when you have consider picture of diabetic nephropathy clinically, if you do biopsy, you can still 1/3 can have. Okay. Now, what do you think? What is the cause of this? What infection you are saying? Acute nephritic syndrome, post-infectious glomerulonephritis. What infection? Or we don't
viral
know.
Infection. Actually, we don't have any evidence to suggest any, but viral infection.
Okay. What are your findings? Expected findings on biopsy? What do you expect on biopsy?
So in the biopsy, in the light microscopy, I will expect I would like to express a diffuse proliferative glomerulonephritis pattern, and in the immunofluorescence, I will expect a C3 dominant staining. There may be immunoglobulin staining also, but mainly C3 dominant staining in the IF. And in the electron microscopy, there can be presence of subepithelial humps.
That is how you describe biopsy? Whenever you describe kidney biopsy, how do you describe it? So straight away you go to diagnosis.
No, sir. So the light microscopy is expressed as the four components: the glomerular component, the tubular intestinal component, and the vascular component. So these are the and the tubules. So these are the four components that are expressed in the biopsy. First, in the glomerular compartment, the number of glomes and what the glomes are expressing, that is in the mesenterium, whether there is any hypercellularity in the what is the status of the in the whether there is an endocapillary proliferation or not, and whether there is any subepithelial deposit. So these comprise of the glomerular compartment.
In right
We also see
microscopy, in right microscopy, how do you see? How do you look for? You are saying, na, we look for endocapillary proliferation. In right microscopy, how do you look for?
Yes.
What will be, how the
infiltration of
have you seen biopsy yourself?
The leukocyte.
Have you seen kidney biopsy yourself? Did you see kidney biopsy?
This patient I have not seen.
Why? If the biopsy was available, why you didn't see the biopsy? That's why you are saying that on right microscopy I will look for I will see endocapillary proliferation. If you know how the glomerulus, what is the term used when you see the glomerulus? How does it look?
It looks like a tuft of capillaries.
No, on right microscopy, will you see epithelial cells, endothelial cells? You will just see a hypercellular glomerulus. It will be a hypercellular glomerulus. It will be a hypercellular glomerulus, the full glomerulus. Lot of infiltration by cells. Even sometimes cells you can't describe which cells are there. That's why you go to which examination now? First you see under low power. Then you go for high power.
High power.
So then under high power, what will you see? Then you go for EM. And then you go for immunofluorescence. So what will you see on high power?
The characteristics of the cells that are present in the glomerulus, and the position
describe the findings,
the location.
Describe your findings in this patient. Yes, Dr. Ritesh. Describe your findings in this patient.
Yeah, that's what Dr. Bhalla is asking you. Go stepwise and each compartment describe the picture of diffuse proliferative glomerulonephritis. So you just go by the basics.
So in the low power, I'll see the glomerulus and the cellularity in the glomerulus as a whole. After that, when I'll go look into in the high power, I'll like to see the where the cells are located, whether in the mesangium or in the basement membrane of the, and the characteristics of the cells, whether there are predominantly neutrophils or lymphocytes, that I can also assess in high power.
So here you will see that I will see the endocapillary. There will be endocapillary proliferation. So there will be proliferation of endocapillary cells. Okay. Now what will happen? More important is that you have a lot of neutrophilic infiltration. Neutrophilic infiltration.
Yes.
There is a endocapillary proliferation plus neutrophilic infiltration. And on EM only, you will see, don't mention subepithelial humps on right microscopy, okay? On EM, what will you find?
Subepithelial humps.
And on immunofluorescence, you will see, what is the pattern, classical pattern called?
C3 dominant staining.
T3 and IgG. And what this
IgG,
deposition is
yes.
called? What is this called pattern? Granular pattern or starry stripe pattern?
Starry sky or the garland pattern.
And what another very common findings you see on light microscopy when patient is requiring dialysis? What additional finding you invariably see in these patients? See, my questions are very simple, very practical. I don't want to go into theory. Well, patient is on dialysis. What you expect on light microscopy?
Crescents.
Yes. So crescents are very common.
Yes.
Does a crescent means RPGN? Suppose you find it one or
No,
two
sir.
crescents. So it may not be RPGN, but you will have crescents. That's why patient is requiring dialysis. That's why there is so much foreign GFR. What on biopsy correlates with hematuria, and what on biopsy correlates with massive proteinuria? What you said in this patient?
Crescents relate with. So hematuria is related with the cellularity and the if there is presence of
hematuria is related with the capsule endocapillary proliferation and capillary injury. So hematuria is related to capillaries. Fall in GFR is related to crescents and degree of infiltration of cells. And subepithelial humps are responsible for proteinuria. There is a clear-cut correlation with the findings. If you have more subepithelial humps, patient can have nephrotic range proteinuria. What are the poor prognostic factors in a patient of PSEN?
Sir, first is the age. Second is the degree of oliguria.
What age? Age what?
Yes, sir. Hello.
How age is important?
Sir, in children the prognosis is good. They recover almost completely after this. In adults the prognosis is bad than the children. Second is the degree of oliguria. So more the oliguria, more is might be the crescent. So oliguria is a prognostic factor. Second is a nephrotic. Third is a nephrotic range proteinuria. The more is the proteinuria, the worse is the prognosis. And comorbidities is also an important prognostic factor. Malignancy, diabetes, malnourished. So these have a worse outcome.
Have you read PSGN or not?
Hello.
Okay. So number one, whether it is epidemic or whether it is sporadic. That is the most important thing. Have you heard of epidemics and sporadic cases? One is sporadic PSGN, one is epidemic PSGN. Do you know what were the various epidemics in the history? Epidemics of PSGN, epidemics of streptococcus infections. Don't know.
No, sir.
Okay. So which one has got better prognosis? Epidemic PSGN or sporadic PSGN?
Epidemic. Not totally sure.
So epidemic clearly has got much better prognosis than sporadic. Number one. Number two, which has got better prognosis, skin or throat? Whether it is skin infections, boil versus throat infections.
Throat has a better prognosis than the skin.
Are you sure?
Throat infection has a better prognosis than the yes, yes. Skin infection has a worse prognosis.
What? How much is the you can say that how much is the incubation period or the gap between the infection and the renal involvement? How much is the time interval?
So if it is a skin infection, then yes, sir. So if it is a skin infection, that is usually 7 to 10 days. If it is a throat infection, then it is a 2 to 4 weeks usually.
Throat infection is 2 to 4 weeks. Skin infection is usually less than 7 days, and throat infection is usually 7 to 14 days, not 4 weeks.
Skin is
Shorter. Now, what about degree of renal failure? If creatinine, at what creatinine prognosis is worse, and at up to what creatinine prognosis is good? Don't know. Hello?
Sir, sorry, my connection got lost. Hello? Hello?
At what creatinine
Hello? Yes.
level of creatinine, where prognosis is good or bad?
So level of creatinine doesn't correlate with the prognosis.
क्यों भाई? ये तो बहुत important factor है. If a patient has got a creatinine of more than 2.5 milligram at presentation, it definitely has got a worse prognosis. Then the creatinine is less than 2.5. How can you say that a level of creatinine has got no prognostic value? That is very important. In fact, the hematuria as well as proteinuria, they don't have much prognostic value. But you said that nephrotic range proteinuria has got worse prognosis. It is wrong. Similarly, hematuria, presence of hematuria dross or absence of hematuria has got no bearing on the prognosis. What about other things? What can be the conditions where complement levels can remain low in post-infectious glomerulonephritis? What happens to normal?
So it normally returns to normal. So normally the complements return to normal at about within 1 month of this.
Not 1 month.
But
6 to 8 weeks.
if there is a prolonged, yes.
6 to 8 weeks. And if there is a prolonged hypocomplementemia, then what is the diagnosis?
It can be a C3GN. Hello.
हाँ बोलो अभी तो आप you have to give me 3-4 causes.
C3GN, dense deposit disease, and
Infective endocarditis, shunt nephritis, lupus erythematosus. Some patients of IgA nephropathy also can have. So SLE, infective endocarditis, shunt nephritis, C3 glomerulonephritis, these are the common causes. And previously, as we were saying, type 2 MPGN. Okay. So now you are saying even that is a part same C3 glomerulonephritis versus dense deposit disease. So these are the you should suspect when there is a prolonged hypocomplementemia. So these are the prognostic this thing. What about any long-term series studies you know of what is the long-term prognosis of PSGN?
it is normally good. It resolves spontaneously after about 4 weeks.
Okay. So this patient's creatinine has come to 1. Okay.
No, sir. 2.
No, I'm saying suppose it has come down to 1. So now patient has recovered. So you will say bye-bye to the patient and go. Okay. That is what is your interpretation of good prognosis. what is the natural history of a PSGN, adult PSGN? Do you know any series which has been done or over a long-term follow-up of many years? What is Baldwin series?
So
that is a very important series. In that series, they did biopsy at 2 years, then they did biopsy at 9 years. And they looked for proteinuria as well as hematuria and hypertension at 2 years, hypertension and proteinuria at 9 years. And they found that about 24% patients had got at 2 years, which you are saying normal. And the same patients, when they followed up at 9 years, 48% patients had got hypertension as well as proteinuria at 9 years follow-up. So it is not a benign disease. It is not that prognosis is benign. It is only in children and pandemic cases when you have a epidemic of infection, strep infections. Otherwise, prognosis is not benign. So there is a doubling at 9 years. If 24% at 2 years and 48% at 9 years. That is the most important series, Baldwin series. Dr. Ritesh, please.
Right, sir. Maybe we can ask now what were the biopsy findings in this case?
Yes, good.
So in the biopsy, in light microscopy, the glomerular compartment. So there were 8 glomerulus which showed endocapillary and mesangial hypercellularity. 2 glomes were showing early crescent formation, and few glomes showed subepithelial deposits. In the tubulointestinal compartment, there was acute tubular injury in the form of dilatation of tubules. Few tubules showed neutrophilic tubulitis. Interstitium, there was mixed inflammatory infiltrates in the interstitium, and there were 5 to 10% IFTA. In the vascular compartment, there was mild subendothelial hyalinosis and no evidence of vasculitis. In IF, there was C3 staining along the capillary loops and the mesangium. Immunoglobulin IgA, IgG, and IgM were negative. C1q was negative. Kappa lambda staining was negative. EM we do not have. It is not being released yet.
How many glomeruli were there?
8, sir.
And crescents?
2 glomes showed early crescent formation.
Were these cellular or fibrocellular or fibrous?
That was they had no, sir. It was not commented upon. We talked. We spoken to the pathologist. She is in cellular crescents. These were 2 glomes.
So what is your diagnosis? Biopsy diagnosis.
Post-infectious glomerulonephritis.
No. Biopsy diagnosis. How can you say on biopsy it is post-infectious?
Also with history of.
Did you see streptototal antigen in biopsy?
Diffuse, yes. This is the diagnosis of diffuse proliferative glomerulonephritis with C3 dominant staining.
Yeah. With crescents, without crescents?
With early crescents.
And interstitial fibrosis or interstitial nephritis? Interstitial inflammation.
There was inflammation. So tubule shows neutrophilic tubulitis, and interstitium also shows inflammatory infiltrates.
So how will you treat this patient now?
So I would like to give, apart from the management of the symptoms, adequate blood pressure control, I would like to give him steroids.
Steroids you will do this, give to this patient now. क्यों जी, Dr. Ritesh?
Sir,
Yes.
another question from him. Like, you say this is C3 dominant deposit. There is no immunoglobulin here. How do you explain
No, sir.
in post-infectious glomerulonephritis? Why is this not C3 glomerulonephritis?
So I'd like to do a complement level post this after recovery. The patient is in recovery, and he has initially a complement level, low complement. I will like to repeat a complement and see the complement levels in follow-up. If it is persistently low, then I will think of if it is improving, then my
The
PIGN will be.
biopsy picture on immunofluorescence, which is C3, purely C3 deposit, right? There are no immunoglobulin.
Yes, PPO C3. Yes, no immunoglobulin deposit.
So why is it being labeled as a post-infectious glomerulonephritis? What are the typical immunofluorescence findings in a post-infectious glomerulonephritis?
Subepithelial deposits.
No, but what kind of deposits are those? They are immune complexes. And immune complexes are made by immunoglobulins along with this. So why is there immunoglobulin here? Only complement C3. Isn't that unusual?
Yes, if there are no if there are no IgG, if it is only C3, then what is the diagnosis?
C3 glomerulonephritis.
But you made a diagnosis of post-infectious glomerulonephritis after looking at this biopsy also. This is purely C3 deposits here.
Yes, immunoglobulins are negative.
So you're going to get a low C3 in any which is. That will not help you right now, no? So right now you're not clear about the diagnosis also. Is it possible that during the time course, as the recovery of post-streptococcal glomerulonephritis is happening, you might find a change in the immunoglobulin immunofluorescence pattern?
So I'm not sure about.
Have you read about C3 glomerulonephritis, or you read only about post-infectious glomerulonephritis after the case?
No, so C3 gen I have not read.
Because when you look at the biopsy picture, your diagnosis would become C3GN rather than post-infectious. These are areas which are a little overlapping. And that is how the diagnosis of C3GN is being made when you have purely dominant C3 deposition on the biopsy. So what is C3GN? It is an abnormality of the alternate pathway of complement. And then you will go into complement studies here.
Yes.
These people can also present like this. Many times an infection is a trigger for the complement dysfunction. That is the second hit in the complement abnormality. Anyways, as Dr. Bhatt was asking you, now you have a patient. Let's say it is, for sake of discussion, post-infectious glomerulonephritis. He was dialysis dependent. He came to you in a stage of recovery. You have done a biopsy and you're seeing that there is recovery. Why would you want to give him steroids now? That is the question. What is the justification of immunosuppressing him now? Or rather, when do you immunosuppress these patients? Do you treat
The
all
biopsy shows
post-infectious GN with steroids?
No, sir. No, sir.
So when
No, sir. No, sir. No, sir.
which are the indications?
So if the biopsy shows crescents, then we give steroids. Otherwise, there is a symptomatic management for.
So because there is some early crescent formation on this biopsy, you are suggesting steroids.
I will like to follow up this patient. If the serum create, if the renal function gradually improves, then if the serum creatinine gradually does not improve and he has a renal dysfunction persistent, then I will like to give him steroids. Otherwise, if he's improving and in the follow up, if the creatinine level goes down and the patient is symptomatically better, then I like to hold steroids and only give him antihypertensives as the case.
So how long has this patient been with you now?
So he has 1 week.
And what has been the trend in his renal parameters in this 1 week?
In 1 week, his creatinine was 2.8 on discharge, and now it's persistent with 2.8 after 1 week.
So it has plateaued at 2.8.
Yes, sir.
That's why you're suggesting steroids. You had baseline creatinine on him
Yes.
2 months ago, isn't it?
Sorry, sir.
What was his baseline creatinine before the illness started?
1.
Yeah, so his kidney function
Around 1.
covered to
Yes,
the
around.
baseline, and you're seeing a creatinine which has now plateaued at 2.8, and there are suggestion of crescents on the biopsy. That is why you're suggesting steroids. And you're sure he was not given steroids earlier?
No, sir. I asked him for steroids and any drugs. He doesn't say that he was given steroids.
Okay, and how would you prognosticate the patient? What will you tell him for the future? His outcomes, what to expect?
Usually in long term, we'll follow up with with the renal function and see for the extent of renal recovery. If the creatinine doesn't go to the baseline, then he might be developing CKD in the long term.
What did Dr. Balaji tell you about the earlier study? Even if his creatinine reaches, say, 1.2, you have seen some things on the biopsy which are suggesting chronicity, isn't it? Already.
Yes, sir. Already.
What was?
Yes. So 5% if it was there.
Only 5%?
Yes, sir. Only 5%.
And nothing to suggest chronicity on the glomerular compartment? No glomerulosclerosis?
No, sir.
Okay.
No, but you said some fibrous crescents were the fibrocellular crescents.
Cellular crescents.
They were all cellular. Okay.
Yes. Two crescents. Sorry.
You didn't say about treatment. You just answered one question that was steroids. So steroids are usually given if you have more than 30% crescents, not less than that. And otherwise, if a patient is having severe renal failure and is not improving, then sometimes methyl steroids have been tried. Otherwise, steroids have got no role, and then there is no role of other immunosuppressive drugs. What about antibiotics? What about antibiotics?
Yes, sir. Treating if the patient comes to us in having infection, then early treatment of infection with antibiotics will prevent the occurrence of the
So
disease.
if there is active infection, that has to be treated. But otherwise, there is no role of antibiotics. Just because it is PSGN or diffuse proliferative glomerulonephritis does not mean that you should give antibiotics. What about antihypertensives?
Antihypertensives we should optimize.
Which antihypertensives?
And give. So we can give non-HP CCVs and the calcium channel blockers, beta blocker. The renal safe antihypertensives we can give apart from the ACE inhibitors.
What is that type of hypertension in these patients? What are the two types of hypertension you know?
One is due to the fluid overload, and
salt
the
and
second,
fluid retention.
Salt and
that is
fluid
one.
restriction.
And second is?
Second is the due to the capillarities and infiltrates in the exercise.
Two types of hypertension कौन सी होती हैं जो mechanism of hypertension?
Renovascular hypertension.
So renin mediated hypertension, and second is salt and volume dependent hypertension. So in PSGN, AGN, it is which kind of hypertension?
Fluid and salt and fluid retention.
So then what is the main treatment for that? Number one treatment for that?
Diuretics.
So you have to give diuretics. Then you have to give vasodilators, calcium channel blockers. Okay. So this is the choice of antihypertensive. And the prognosis already we have told you, already we have discussed with you. Okay. Now, what is the significance? When you say that there is a significant hematuria?
If the RBC is more than 5 per high powered field.
Any last question, Dr. Ritesh?
No, sir. I think what we need to understand, Debayan, is that in the examination, in your exams, you have to stick to your basics. Don't worry too much about what the biopsy is showing, but your diagnosis should be based on what the patient's history is. Here you were told that he has a kidney biopsy which is showing some features of post-infectious glomerulonephritis, but you should support it on your history. That's what, most important, your differentials. And those differentials should be justified. You can say that there are certain points which are against it, and there's nobody's going to kill you for that. And that only tells the examiners that you know and you understand what the disease process is. So nephrology is all about syndromic diagnosis. You begin with the syndromic and then go to their histopathological diagnosis. So first talk about the syndrome and then what could be the possible etiologies. And that's where your history is most important. And your history, in this case, as the time frame went, did not actually support an acute nephritic illness. It was more pointing towards a rapidly progressive course. So you might be questioned, then how are you saying this is an acute nephritic illness?
Yes, I think you have summarized it well. Thank you, Bhai. Thank you very much.
Thank you, sir.
Thank you so much, faculty.
Okay.
Thank you, sir.